Thanks so much for the invitation. This could be a tricuspid case. As you know, tricuspid clip is an off-label procedure. So just as a disclaimer. So I am the site PI along with Paul Suraja and Zabel Carr for the Triluminary TriClip feasibility study. So this is the TriClip system. Essentially, it's the same as a MitraClip NT, but the guide delivery is a little bit shortened and a little bit of a angulation in terms of more favorable to the tricuspid valve because the shorter distance travel. This is a prospective single-arm multi-center feasibility study involving European and U.S. sites. There are 3 in the U.S. sites and possible expansion in the U.S. The pivotal trial is going to be probably next year. The criteria is moderate greater TR of NYHA class 2, 3 or ambulatory 4. 3-year follow-up. The endpoint is TR reduction at 1 grade, at least 1 grade 30 days, and secondary endpoint of cardiac mortality. So these are inclusion criteria. Moderate, severe, or greater TR by core lab has to be appropriate heart team to high risk for surgery. No indication for mitral valve intervention and suitable tricuspid anatomy by imaging. Exclusion, if you have concomitant moderate, severe, greater MR, you have to fix that first. Moderate pulmonary hypertension right now is an exclusion criteria. Any leaflet surgery done was excluded. Pacemaker IC lead is not excluded, provided that it doesn't interfere with the procedure or imaging. Right now, age over 90 is excluded and also in dialysis. So I just want to talk to you about our first case at Mount Sinai. It's a 72-year-old female, NYHA class 3, peripheral edema, polycythemia, myelofibrosis, on home oxygen. She has also a permanent pacemaker with AFib. She just made the criteria for pulmonary hypertension. We also actually did a MitraClip repair for her severe primary MR a year ago with ASD closure, given the right to left shunting cross. And you can see she's on optimal medical therapy already. You can see this is the baseline TEE. You can see here, TTE rather. So you can see here, right ventricle, in the anterior posterior leaflet. You don't see the pacemaker lead in this view, but I'll show you in another view. So one thing we learned is that if you have to have a reasonable septal leaflet in terms of mobility and not over-restricted, you can see that's the pacemaker lead here. And it's quite mobile. It's actually go towards the central orifice. And you can see this is the TR location, which is more along the anterior posterior, relatively central. It's a functional TR. And you can see here where the pacemaker lead across. The challenge with this is that how do you actually navigate the catheter around without interfering with dislodging the lead, given she's pacer dependent 70% of the time. This is a 3D T. You can see again where the lead is placed and where the TR is. So first, we went after the anterior septal commissure, given that is the more favorable trajectory for this particular device. You can see here this is the grasping wheel around usually 150, 140 to 180 degree angle. It is a bit of a challenge within with the thinner tricuspid leaflets, how to confirm leaflet insertion. You can see this is where the clip is closed, and you really have to make sure that you have sufficient leaflet insertion to avoid the risk of detachment. And we often actually would re-grasp more than once just to make sure on echo we can see that, and we record it so that we can get confirmation. So we also use a combination with fluoro. Fluoro has been extremely helpful, actually, in this procedure, at least in my opinion. You can see here the anterior septal and posterior leaflets are roughly in this kind of orientation, LAO. And thankfully, in this patient of ASD occluder, you can also guide roughly where the septum is. And you can see this is RAO, roughly the trajectory of the anterior septal device. Now, this is the anterior posterior. This was our second clip target. You can see the first clip's already poured here. It's a little bit closer to the commissure. We were concerned about interacting with the lead and also with the mobile lead interacting with the clip acutely that can cause dislodgement. So we placed a little bit further away. And you can see here the challenge with this particular location is that you literally have to go above the lead and then reach underneath. You can see it on fluoro here on the RAO view. You have to go above to maintain a favorable trajectory, and then you have to actually go around it. So what we do is actually the whole respiration, also do about Valsalva maneuver before we cross in the ventricle, just to see how the lead can shift in the position before we cross. And we actually hold respiration we cross so that we actually minimize the movement of the lead when we cross into the ventricle. So here you can see here the transgastric is really excellent in terms of looking at the clip orientation. You can see it's the anterior posterior leaflets here. Well, that's the previous first clip. You can see with X-plane, you really can see the leaflets pretty well here. You try to get a view where you don't have to lead across. If you have to lead across, that means you're too close to the lead, so I would not recommend grasping there. So we actually play a little bit safe, just go a little bit more lateral. So here's the final result. You can see one clip here and the second clip here. And again, we also interrogate the stability of the clips with the lead. Again, we would do certain respiration maneuver to mimic more physiological conditions. For example, the patient with Valsalva, would that cause a potential interaction with the clip? So here's the pre-implant. You can see here, in terms of anatomy, this is the post-implant. That's clip number 2. This is clip number 1. You can see here, the lead was quite mobile previously. Now that with one clip there, certainly limit the mobility of the lead somewhat. And you can see this is the pre-implant, and this is the post-implant. Really, we almost eliminate the TR at the anterior posterior segment, where you can see here it was quite significant beforehand. So this is pre-implant, that's Clovis implant. This is 30 days, so she has moderate TR, and most of the TR is actually around the lead. We actually contemplated whether to extract the lead and put in a micra. We've done that in the past. I published that before, but I think given her morbidities and the lead is actually quite old, we worry about obviously laser lead extraction and complications associated with that. So we just enrolled her study into the trial without that, and you can see that's really the residual TR. So in summary, I think HUS repair tricuspid with existing pacing lead is challenging, but it's feasible. Really, at least in my experience, the combination of echo and floor guidance really help you put in the right spot without interacting with pacing lead, and respiratory maneuvers can really help confirm the absence of interaction. Thank you.
Great case, Dr. Tang. I mean, the imaging seems to be a crucial role here. So any comments on how the imaging people are orienting to the whole process?
Yeah, so the number of papers published in the literature showing the protocol essentially on TTE and TEE imaging in terms of the screening these patients. We routinely, before we screen these patients in our clinic, optimize them. So work with our heart failure colleagues to make sure they're medically optimized. As you know, the loading condition can shift the tricuspid gap and also the pathology quite a bit. So we optimize them, bring them to the lab, and some of the things that we learn is if they have previous mechanical valves, is a big problem because acoustic shadowing, we learned that. Pacing lead ICD is also a big problem. Not that the anatomy is not favorable, but that the imaging, the acoustic shadowing really hurt you on being able to do a grasp at the time of procedure. So those are the things we look for at the time of screening, as if you were going to do the procedure and be able to really accurately determine whether the patient is suitable or not.
Thank you.
Yeah.